how big a name I may be in India. For them, what matters is what data can I show them, what results can I show them, and how I can prove what I'm doing. So this is where we lack very drastically. 30 years back, it was really not that big a thing that was needed either, but today we understand the importance of it. So at the outset, when you start your practice, if you get into the habit of documenting everything that you do, it will go a long way in supporting your practice. So like I said, either your own scope or access to the scope, you must be having the ability to do. The mouse, Satya. Okay, doesn't really matter. Oh, okay. No, it's not going to play. Leave it here. It's not important. These are the sleep labs that are all available to you. You will have to pick and choose. There are multiples that come. We used to do a sleep study on your left side of the screen is the level 1, which has all the multiple electrodes that you need, and on the right side of your screen is a level 3, which is done home based. Huge discussions will keep happening. We've had huge discussions about level 1 versus level 3. The bottom line take home message that I can give you without getting into too many details is the fact that yes, level 1 remains the gold standard, no doubt, but there are issues with accessibility, availability, cost factor. It's obviously much higher. You need technicians, you need to be sitting there through the night, that fellow's got to be evaluating it, and it has to be done in a hospital setup. So that's an issue. A level 3 PhD done at home makes it very easy for us because it gives you the same 4 parameters that a level 1 also otherwise gives you. So in the level 4 that you, level 3 that you see, you have abdominothoracic belts, you have pulse oximeter for the oxygen, and you have a nasal airflow. So all it needs to tell me is how much is the desaturation. If I see abdominothoracic belts struggling, the belts will realize when you're struggling. And at that very instant, if I see a drop in oxygen, meaning a desaturation event, and I see a block in the nasal airflow, it's a clear-cut obstructive event. It's understood. The patient is trying to breathe against obstruction and the saturation is falling. Vice versa, a central event where there will be no abdominothoracic movements, but there will be a desaturation and there will be no airflow on the nasal cannula. So it is enough for me to know whether it's central or an obstructive event. These are the same parameters used in a level 1, but these have additional EEGs, EMGs, chin myography, tibialis anterior myography, and a lot of other things which we use only if we are suspecting any other kind of central pathology with an obstructive event. So in a history is when you decide whether you want to do a level 1 or a level 3. A level 1 we tend to normally ask nowadays very standardly if in history you find anything which is a little suspicious, or if there is something in your history which is not collaborating with your clinical findings that you've seen. So there's a mismatch somewhere, or if there's any kind of issues with say narcolepsy or other central issues or any other kind of CNS issues that you feel, or even if it's a pulmonology issue where there's a lot of say ILD or any other fibrosis or something like that, anything, even a COPD patient is best done with a level 1. So in short, when I put it, when I give talks on PhD, is that any patient of suspected OSA with associated comorbidities needs to go for a level 1. And the associated comorbidities could be in any form, central, respiratory, or anything else that you suspect, or a disproportionate clinical history correlation. That's when you do a level 1 or a level 3. So this is not very difficult to own also. It's again disclaimer, I have nothing to do with the companies. We're just telling you that Philips Alice PDX4 is the machine. They give it to you, I mean you have to buy it, and they give you with a software. So you have to understand how to use the software a bit primarily also, because you need to know that how are you going to take the reports out. If you don't know how to remove the reports, how are you going to decipher it? Initially you must learn, later on obviously your technicians do the job, we don't do any of all this. You have to learn how to read the sleep study. Like I told you, you will have many parameters. What we will be interested is, if you can see here, we will be interested in central events, we will be interested in obstructive events, we will be interested in the desaturation here, and we will be interested here in the BMI or the weight. That's what we will be interested in. And you learn to read the reports. You learn to also categorize, or rather score your own reports. Like I said, these are central events here. So you see zero effort, you will see a pulse drop, saturation drop, and you will see a flow restriction. So that would indicate to you central, right? But when you see effort and you see a saturation drop, let's say here, effort, saturation drop and lack of airflow, that would be obstructive, right? So you can read, you have to learn to read about a polysomnography from places, and these are the few things that you need to understand. Like I told you, you will have to see the sleep efficiency of your study, very important, because unless you give credit to that sleep study, if the sleep study is to be rubbished away, then it's pointless. Then you're not going to learn, you're not going to give importance to that sleep study. And you will look at central events, you will look at the saturation levels and the AHR. This is what I told you what you need. Then you need to understand a bit about PAP machines. Okay? Because your patient is going to ask you, you have to learn a few things about the masks, about the delivery system, about the auto titration, about the regular titrations. You need to learn about these things, basics. You don't need to get into too much detail. There is also something called as a split night study. For me, a split night study is just something to be spoken on an academic platform. I don't ever do it because it doesn't really make sense that you do half a night of sleep study and the second half you do a titration with a CPAP machine. So you have already broken the REM sleep stage cycles of that patient, and then you're putting him on half this. So there were a lot of logistic issues why this came up. It was said that, oh, patient is from out of town, we don't have time, we have to do it all in one night, blah blah. But over the years, what I have realized is your logistic answers cannot be an answer for academics, because just to try and cut corners, you are lining up doing a lot of things which are not, I would say, proper. Then DICE. You all have to learn about DICE at least. Yes, it's important to know how to do it. This is also not going to play, so it's okay. But there are places where you can learn this from. There are books, there are workshops you will learn, but I will tell you later on why we don't need it. I also got into that same cycle, so we started doing DICE, and whenever I used to talk to a chest platform, so the national chest people, when they would invite me, their biggest objection against anything I did was the fact that, oh, when you do your DICE, you don't know at which stage of sleep you're doing DICE in. So the obstruction changes at different levels of sleep, which is very correct because they are academicians and they will talk academics without understanding the logistics. So then what we started doing is we started doing an intra-procedural PhD. So we started doing a DICE with this. So on one corner on the monitor here, I'm seeing the obstruction. On the other one, we're doing a PhD where the patient is hooked up completely like a regular PhD to do that. And I started doing a lot of this just to prove to them that, okay, I know at what level of obstruction it is at what stage of sleep. Now again, what happens over the years is you start realizing that what are you doing this for? Is it making a difference to me? Is it making a difference to my management of the patient? And my first principle, which I also teach most of my residents, is any investigation needs to be justifiable. If that investigation is making a change in your management, then that investigation is justified. You can't just do an investigation at the end of the investigation, say to the patient that nothing has changed, and then we are continuing the same. So if you remember in yesterday's DICE when it was being shown, this was my question which I put across to Srinivas. And I asked him, I said, when you did the pre-op flexible scopy, and when you're doing the DICE now, has it changed your plan of management for your palatal surgery? And what was the answer? So that's where I'm going to be in the cross-firing line today. And I'm going to say this very openly. If an investigation does not change your management, that investigation is not justifiable. Even in a court of law, even on an academic platform, and most importantly, to your patient. You're making him do an investigation and then say, okay, I'm still going to continue doing this. Then why did you do the investigation? So then I stopped doing this. I started telling the chest people that, okay, my decision making is not changing because of this. How does it matter to me at what stage, what is the obstruction, when I'm anyway going to deal with that obstruction? I'm not leaving that obstruction as it is, right? So this is the point against DICE that I very strongly amplify. If I have a lateral collapse that I see on an awake scopy also, my decision for my palate is made because I'm going to address that lateral wall collapse. Then it doesn't matter to me whether that lateral wall collapse is 20%, 40%, 60%, because I myself know that when I see a 20% collapse on a flexible awake scopy, I know that in sleep this is going to worsen. We know that. It's not rocket science to know that it's going to worsen with DICE when you put the patient to sleep. So how does it make a difference? For the palate, hear me out very clearly, I'm talking about the palate. Because DICE was brought out to say that palatal surgery decisions change because of DICE. And now I'm telling you very clear cut that if anyone in the audience can get up and tell me that if you've seen 20%, don't touch it. If you've seen more than 40%, you touch it. If you see 39% also, you don't touch it. If anybody can tell me that with conviction, then I will do DICE. Otherwise, I know I've seen a lateral wall collapse and I'm going to address it, period. So it doesn't change my decision at all. And that is the reason why DICE is overrated. We don't need to be doing so much of DICE. Right? It's not just for the palate. You are talking about, then it goes further and it becomes like, okay, we need it for the epiglottis or we need it for the base tongue. Now you have to understand that nobody ever does a palate with an epiglottis in one setting. And it is not advisable to do a palate with a base tongue. Sorry, just 1 minute. Just a second. Right, so we don't do a palate and an epiglottis, we don't do a palate and a base tongue. So unless you're doing a single stage multi-level surgery which involves all of these together, all of these, then a DICE doesn't make sense. And how many of us would ever do all of these together? So the other part is when you do a DICE, when you do a palate surgery and you wait for some time, the dynamics of the Bernoulli's phenomena changes. So what you had narrowed above is now opened up and the collapse patterns could totally change. So maybe what you didn't see earlier, you will see betterment and you may not need to do an epiglottic work later on. So how does it justify doing the DICE at that time? So you do a palate surgery, wait for about a month or two, and then if the patient is not improving and if you have issues with the question marks on the epiglottis or base tongue, then you do a DICE at that time will be more sensible rather than doing a DICE in the beginning and saying that I did a DICE and all this happened. Okay? And there are umpteen times that I can tell you, as you grow in practice, you will realize that after you've done the palate and things are better, you don't really need to do a DICE. Because when the patient has improved, then what next? Where is the question of doing anything next after we've improved the palate? So DICE, I feel, is inappropriately placed in our armamentarium, and these are my reasons, and I'll argue more at a later date about this. So radiology is important. You need to know from your radiologist. So these will play in my other video, in my other slides, not in this. But in radiology, in dynamic MRI, you heard Vijay say, I also suggest a lot of people to do dynamic MRI also, because it's a simpler way. You can also see pre and post-op improvement. So there's a radiofrequency palate done, radiofrequency base tongue lesion where see the improvement of the airway. You need to take little efforts in going and talking to your radiologist and giving them a protocol of what you need. So it will give you vertical obstructions. It will also give you sagittal cuts and tell you exactly with measurements. This is the best part of an MRI. With measurements, it tells you what is the obstruction, how much is it, etc., etc. Now the problem with MRIs are, again, when I started off, it was new, and I would do an MRI for every patient of OSA. We finished snoring, I would say, okay, we'll do MRI, we'll do MRI. I kept doing a lot of dynamic MRIs to the extent that in my city I got known as very big in terms of dynamic MRIs and OSA. Now the problem that happened was about 2 months later or 3 months later, after doing a lot happened in those 2-3 months, I got a call from the radiologist, and he asked me, sir, we had done the dynamic MRI of that patient ABC. What has happened, sir? We would like to have a follow-up so that we can see post-op. And then I suddenly looked up the records and I said, oh, this guy didn't turn up for surgery. He was not willing. It didn't happen. Again, a few days later, he says, XYZ patient ka kya hua? And I said, oh shit, he didn't turn up. He's not been operated by me. And then when I looked at the internal audit for myself, I realized that a lot of them were doing it, but were not converting to treatment. And as a result, the dynamic MRI was going wasted. It was just becoming an unnecessary expense onto the patient, a bad label for me, because they thought that I was wanting to take the commission out of the MRIs, and I got labeled that way. So and I suddenly realized, okay, this is not making sense. So again, I changed my protocol. So now any patient who needs to be investigated is investigated once he says yes to surgical intervention. If he does not show motivation, like I mentioned yesterday, if it's a non-motivated patient, I will not push. This is after 3 decades of practice. Do not push a non-motivated patient. If he says yes, okay, I'm willing to take the next step, then we go ahead with doing either an MRI, or if at that stage I feel a DICE is needed. If it is just related to palate, again, like I've explained to you, the DICE becomes unnecessary in my mind, rationally speaking. So we are talking logistics, we are talking private practice, we are not institutionalized where the patient gets paid for everything. We don't have that kind of setups. We are all answerable to a patient for everything that we do. A flexible scopy awake in a lying down supine position makes ultimate sense because it is not an invasive procedure. If you have your own scope, it is done in your own OPD and you don't need OT setups. And that, along with a level 3 PhD or a level 3 sleep study, is sufficient enough for us to go ahead and plan. And then once the plan is in place, then you do either a dynamic MRI or a sleep DICE. So of course I dwelled into this, and now the place of this is at that stage. This is what we are now also doing. You heard Vijay speak about it, volumetric assessments. This is the kind of setup that you need to have. Most of us who are working in institutes, private setups, tier 3 cities, tier 4 cities, I don't know, it's sometimes very difficult to ask for everything. But you must try for an absolute ideal setup as much as you can, and it should have everything. And remember to not push your administration in any hospital to ask for tools which you can't justify, because the administration is going to sit on your head for returns on investment issues. So when you're starting off your practice, at least go slow. Ask for the basic things, get your numbers in place, because this is the harsh reality of today's practice. You get your numbers in place, be able to justify the numbers with the equipment that you ask for. Until that time, you can very well do with cold steel. It's not like we didn't do tonsils before the coblator came in. It's not like we didn't do other work without these tools. Right? So it's your surgical expertise that also matters. Your tools are meant to make your life easy for you. And if you can do that, and if you have the power to get that done, perfect. Inside the OT, you will need to make sure everything and anything is needed to keep your airway secure. You cannot, this is airway surgery, so at any cost your airway has to be very secure. If you have the facility to get these kind of video scopes, wonderful, your anesthetist will be very happy. If not, nasopharyngeal airway is an absolute must. There is nothing that you can do without that. I would not suggest that, and it's very cheap. and it's very easily available. We don't keep it, that's all. You don't need flexible scopes or things. I mean, you don't need these kind of video scopes if you can't manage them. Do can get these kind of laryngoscopes. They definitely help in intubations. You need to have ICU backup, right? Very important to have ICU backup. You have to have a very, very good intensivist. You should know what you are dealing with. You should know what you are planning to have at a later date. So there are a few things here which I would have wanted to mention, but we will go in for what I mentioned to you about the trainings. So we at ISSA also have a training program. It's a certified training program, like we've been talking. Rudolph mentioned the training programs that they have at 3 different centers. Ours is on similar lines. 2 months at different centers across the country. We have 5 centers starting with Chennai, Hyderabad, Bombay, Pune. And people can apply for this. You can get onto the website and there will be all the details given to you. Now the other last and proper important few things that I would like to mention to you is self-training. This was about how you build up, how you get there, how you start making people understand you understand OSA without getting proper training from the right mentors, wherever it may be, whether within India or outside. But let me assure you that we are as good as anywhere else that you would like to go to in our country. It's Atmanirbhar Bharat, as we are all talking about, is something of that sort. But you have to have an understanding of intraoral suturing. If you are able to handle intraoral bleedings when you are doing this kind of work, then you are pretty safe. So that needs something, because the learning curve is big. It's not as simple as you would have expected it to be. The learning curve is big. You must learn to handle the tools that are given to you, or the tools that you start picking up. Because like even Dr. Mohan always keeps saying, it's the man behind the tool. If he's a fool, then the tool can't do anything for you. So you do make sure that you have absolute understanding of the equipment that you pick up. And these are some of the ways that you will have to raise your awareness. Initial times when you start off in practice, you will have to get the people to understand what happens if untreated OSA continues in the community. So you will have to get across to your IMA, your general practitioners, your colleagues from other departments, and make them understand why it is important to tackle OSA. Your lectures should be structured. All the talks that you give in your initial years of practice should be structured around these points. You have to bring out these points to the people who you talk to. You talk to them about the pathophysiology. You talk to them and explain to them how easy it is to get investigated. So unless you drive home these points on the platforms where you start your careers with, they will not understand, and then the pool of patients of the understanding will not increase. Initial years, if you are starting off, talk very superficially about treatment. Don't get on to very extreme details. Look at the platform that you are talking to. So if you are talking to an IMA platform, or if you are talking to a multidisciplinary platform, and you waste 15 minutes trying to show them how best you can pull up the palatopharyngeus from here or shift it here and suture it there, it's a waste of the time that they've given you to talk to them. So talk targeted. Talk to them about what they need to know. Talk to them about the diagnosis and the treatment. Do not rubbish away alternatives that are there, because we as surgical surgeons generally tend to have a surgical ego where we say, oh, I can do this and this is wonderful and that is wonderful. So you need to not rubbish away the alternatives, but in fact try to incorporate the alternatives in what treatment is available. So if you also follow our ISSA guidelines, the first and foremost things that we have done is that we have incorporated a CPAP trial as part of protocol of investigation. So thereby we are acknowledging to them that yes, at present today a CPAP is probably the gold standard for the lack of better solutions right now. I'm not saying that that is the only thing, but it is our fault that we have not been able to prove to them. Like Sir said yesterday, he said it is somewhere you have to reflect, introspect. We have not given them the understanding of how surgeons can make a difference. So by default right now that is still the gold standard, and it is our duty to incorporate that in our protocols. Talk about teamwork. This is never a I, me, myself kind of a thing. You will never get. We've grown over 10, 12 years under mentorship of these people because we've learned about teamwork. So in your own city, don't try to have a one-upmanship. Try to get involved with your colleagues. Talk to them. Talk about teamwork. Talk about seeing who's got what strength in handling that patient, and then work accordingly with them. Because that is a very important part of today's practice. You cannot stand alone. Times have changed, medico-legally things have changed, and you will need to have your colleague, irrespective of he is your contemporary. More importantly, some seniors for your guidance are always going to be very helpful for you. Talk about your role in the management. Don't try to overplay that, but talk about your role. The ENT surgeon has to let the other fraternities know how we can make a difference. Then only OSA will come up in a bigger way. Talks, like I said, should be structured around very practical points. There is a different platform for theory. That is something like this. The conferences and workshops that we do here is where we discuss die-hard academics. But the platform that you will be talking to with regards to awareness, don't get too theoretical. The people that you are going to be talking to need to understand that you are doing groundwork. They don't want to know theory which they can also look up. Today everybody has got theory at the click of a finger. And the worst thing that I sometimes notice about a lot of presentations is the fact that it is all internet copy-pasted material and internet copy-pasted photographs. So the minute you see a different photograph on that slide, you know that person is not doing groundwork. Use your own patient with permission, darken their eyes off, block it off, but use your patients in your presentation. It gives a feeling that yes, groundwork is being done. This is not something which is just copy-pasted from elsewhere. And most important, form and be part of a team like this. You have to have teams. That's the only way to grow. This is where we've grown. Thank you, Dr. Mohan, for being here also and being supportive to us. We've grown right from 2011. 12 we started the association. This was the second conference that we had. The first was in Chennai. And you have to have a team. You can't do everything on your own. You can't always be in the spotlight. You can't always be at the dais. You have to let a team grow with you. And that's something that is very important for you to understand. The learning curve is huge, like I said. You have to learn the basics of sleep physiology and PhD. You don't do a FES today without reading your own CT scans. So you don't do OSA work unless you learn to read your own PhDs. It may be whatever little bit worth. I'm so sorry. And then you know and learn to decide when to operate and when not to operate. What to operate, what not to operate, and when to operate is something that is much more at the end of the learning curve than initially when you're when you're trigger happy. This is something which you have to understand as a caveat for us ENT people. There is a huge pathophysiology of OSA, and we are only at that end over there where we are dealing with obstructive part. The rest of it we have absolutely no control of, and for that we should not be harping and tom-tomming too much, saying that okay, we are the people who can do it. Detailed counseling is something that I don't really want to get into because that's something each one has their own individual way of doing it. But the detailed counseling and setting their expectations. So like when I was asked on the panel yesterday and said, what would you do if a patient said that he wants this? And my answer was very clear. I don't fall into patient expectations. I give him what we can do. I set his expectations right. If the patient is non-motivated, I will try to motivate him, but I will not do something that he wants just because he wants. So don't succumb to patient demands. You must know how to handle the possible complications both on table, post-op, even in a pretty short-term duration and in a long-term follow-up failures. So there are times when you can have a situation where the patient may be unhappy. So you need to introspect and so of course this works for every surgery, it's not just for OSA, but this is something that you must keep in mind. We have come out with this. So we have come out with this, it's available on the website. It has everything in it, and you must go through these guidelines because somewhere if you ever have a problem in the medico-legal world, It is guidelines that help you, and as long as you have followed your guidelines, then you are on the safer side. So the guidelines are not just meant because you can say, oh, a bunch of people did this, why should we follow this? No, it's meant because it's a consensus that has happened across the country. It's not 2 or 3 people. It's a consensus which has happened across the country, keeping all the seniors and juniors and everybody involved in the process. And it's not easy to come out with them. Once you have them, the court also always looks at this and whether you followed them or not. So please do go through that. You have to change the total definition of success for surgical treatment over time. Like I was telling you in the initial part, we come around whole circle. AHI, like I said yesterday also, is irrelevant to an ENT surgeon. For what we need, we are not only harping on AHI as a criteria for success or failure. It's like saying that, okay, I've improved so many things, but the AHI has not come within the range that you want it to be in. That doesn't make my patient a failure, especially if I have counseled the patient for a multi-staged treatment protocol. So my first surgery doesn't become a failure, and this is what has been told to us by a lot of people when palatal surgeries failed for them, so-called failed for them. Because probably in the counseling it was not probably decided that we will do stage 2 later or stage 3 later, and the patient landed up with a physician and the physician will say, oh, this doesn't help you. See, it's like that. You need to come back to CPAP. That's not the way it goes. So your detailed counseling becomes very important. This is what we are shifting to, the sleep goal criteria, which is being brought out by Kenny and Brian, colleagues of ours across the world. But it's a much more comprehensive one which encompasses a lot of things, not just an AHI alone. So when you look at something with a much more detailed understanding, then you look at whether the patient is improved or is better or not. You can't just rubbish everything away and just AHI improved, AHI not improved. That's very important. You must go through that. We're trying to support that. A few new things you must understand what's happening in the world today. So these are the newer diagnostic tool that has come out, not validated, but I'm just making you aware of these things. So these are strips. This is one which is called SnoozeFit. There are 2-3 others that have recently come out. These have been engineered by engineers, where this kind of a belt is put under your mattress. It is not put onto you. So they do that, and they are talking about measuring your oximetry or measuring the oxygen saturation based on the vibration of your breathing. It's a newer technology, but what they've approached us and what they've told me, so I only asked for one thing. I said this needs to be validated with a regular PhD. So we do this along with a regular PhD. Let's see both the results, and if both the results are even comparable beyond a particular statistically significant value, then we will give importance to this. But like I told you in the beginning, don't rubbish away anything that comes. We have to keep trying. It's R&D. We will have to keep learning and then decide whether to accept it or not accept it. So that's all I can say to you. We will have interactions if you want. The most important thing that I say to you, which I have also learned in the past 2-3 decades of practice, is the more you know, you realize how much you don't know. Whereas maybe 20 years back I thought I knew a lot more, but here I am today telling you that it really doesn't work that way. So thank you very much, and we have time, we have interactions to do, we have people